Hi, my name is Yvonne, and I am a 2022 PharmD candidate. I will be presenting on Pradaxa, also known as Dabigatran. To start off, I will go over some main patient counseling points. Pradaxa is a prescription blood thinner that lowers the chance of blood clot formation. Pradaxa is not for use in people with artificial or prosthetic heart valves. Do not stop using Pradaxa without talking to your doctor. Common side effects include indigestion, upset stomach, and stomach pain. Some of the more serious side effects include swelling of your face or tongue, unexpected bleeding or bleeding that lasts a long time, such as unusual bleeding from the gums, nosebleeds that happen often, menstrual or vaginal bleeding that is heavier than normal, or bleeding that is severe or that you cannot control, unexplained bruising, pink or brown urine, red or black tarry stools, coughing or vomiting blood, unexpected pain, swelling, or joint pain, feeling dizzy or weak. If you notice any of these side effects, be sure to contact your doctor right away. Pradaxa is a direct oral anticoagulant, or DOAC for short, and it is also a direct thrombin inhibitor. Pradaxa can be used for non-valvular atrial fibrillation, for the prevention of stroke and systemic embolism, for deep vein thrombosis and pulmonary embolism treatment and prevention in patients who have been treated with a parenteral anticoagulant for 5 to 10 days to reduce the risk of recurrence of DVT and PE in patients who have been previously treated. It is also used for venous thromboembolism prophylaxis in total hip arthroplasty and as off-label use for venous thromboembolism prophylaxis in total knee arthroplasty to help prevent blood clots forming in the legs and lungs of people who have just undergone hip or knee replacement surgery. Dabigatran is a competitive direct thrombin inhibitor. It inhibits both free and clot-bound thrombin, preventing thrombus development or thrombin-mediated effects, including cleavage of fibrinogen to fibrin monomers and activation of factors 5, 8, 11, and 13. It also inhibits thrombin-induced platelet aggregation. At recommended doses, dabigatran prolongs the activated partial thromboplastin time, eccarin clotting time, and thrombin time. Dabigatran is only available as an oral capsule in the strengths of 75, 110, and 150 milligrams. There is also no generic equivalent available in the US. Dose recommendations. For non-valvular atrial fibrillation for the treatment and secondary prophylaxis, 150 milligrams twice daily is recommended. For deep vein thrombosis and/or pulmonary embolism treatment, after at least 5 days of initial therapy with a parenteral anticoagulant, transition to dabigatran in hemodynamically stable patients at a dose of 150 milligrams twice daily. The optimal duration of therapy is unknown and is dependent on many factors, such as presence of provoking events, patient risk factors for recurrence and bleeding, and individual preferences. For provoked venous thromboembolism, a duration of 3 months is recommended, provided that the provoking risk factor is no longer present. For unprovoked, a duration of therapy greater than or equal to 3 months, depending on risk of VTE recurrence and bleeding. Venous thromboembolism prophylaxis in total hip arthroplasty or total knee arthroplasty as an alternative agent. For total hip arthroplasty, an initial dose of 110 milligrams given 1 to 4 hours after the completion of surgery and establishment of hemostasis, or when dabigatran is not initiated on day of surgery, you want to give an initial dose of 220 milligrams after hemostasis has been achieved, and then continue with a maintenance dose of 220 milligrams once daily for a minimum of 10 to 14 days. The optimal duration of prophylaxis is unknown, but is usually given for a minimum of 10 to 14 days and can be extended for up to 35 days. For total hip arthroplasty, a duration of 30 days is recommended. For off-label use for total knee arthroplasty, a duration of 10 to 14 days is recommended. Dose adjustments for renal impairment. For non-valvular atrial fibrillation, with a CRCL greater than 30, no dose adjustment is needed. For a CRCL 15 to less than or equal to 30, 75 milligrams twice daily is recommended. For a CRCL that is less than 15, you want to avoid the use of Pradaxa. For deep vein thrombosis and/or pulmonary embolism treatment, and for venous thromboembolism prophylaxis with a CRCL greater than 30, no dose adjustment is needed. And for a CRCL less than or equal to 30, you want to avoid the use of Pradaxa. As for hepatic impairment, there is no dose adjustment needed. Precautions and contraindications. You want to avoid the use of Pradaxa in elderly patients with a CRCL less than 30 milliliters per minute due to a lack of evidence for efficacy and safety. You want to be especially cautious in patients 75 years or older due to increased risk of gastrointestinal bleeding. Pradaxa may increase the risk of acute coronary syndrome. Significant and potentially fatal bleeding has been reported, especially in the very elderly, with labor and delivery, and with concomitant use of drugs that increase bleeding risk, such as antiplatelet agents, heparin, fibrinolytic therapy, and chronic NSAID use. Pradaxa is not recommended in patients with triple-positive antiphospholipid syndrome due to increased risk of recurrent thrombotic events. Invasive or surgical procedures increases the risk of bleeding. You want to discontinue prior to the procedure or weigh the benefits versus the risks. For spinal or epidural hematomas, they may occur with neuraxial anesthesia or spinal puncture in patients who are anticoagulated. This may result in long-term or permanent paralysis. For contraindications, you do not want to take Pradaxa if you have a serious hypersensitivity reaction or anaphylactic reaction to Dabigatran or any components of the product. If you have any active pathological bleeding, or as mentioned previously, in patients with mechanical prosthetic heart valves. Monitoring parameters. You want to be sure to monitor the complete blood count, activated partial thromboplastin time, prothrombin time, serum creatinine, and liver function tests prior to initiation when clinically indicated and at least annually. Routine coagulation testing is not required or necessary. There are currently no FDA-approved assays or calibration reagents available. Here are my references, and thank you for listening to my presentation.